I wanted to just introduce our first speaker, Dr. Akshay Shetty, who is Assistant Professor of Clinical Medicine at UCLA. And he actually did important work when he was in Texas, in Houston, regarding alcohol-related liver disease and post-transplant care. And what I didn't know is that we are fellow Emory resident graduates when I was reading his CV. So without further ado, Dr. Shetty.
Good morning, everyone. Let's see. Thank you, Dr. Khan, and to all the organizers for having me here. Today, we'll talk about transplant and alcohol-associated liver disease. So I have no disclosures.
I try to check.
Over the next 20-25 minutes, we'll discuss the evolution of liver transplantation for alcohol-associated liver disease, outcomes for alcohol-associated liver disease, and discuss a little bit about selection criteria, and then focus on relapse and alcohol use disorder. So a big change over the last 4 to 5 years has really been a change in terminology where we're trying to avoid using the term alcoholics. It really carries poor stigma associated with it and undermines patients' dignities. So we're moving away from describing patients as alcoholics and instead describing their disorder as alcohol use disorder or their liver diseases, alcohol-associated liver diseases. And as we see in our clinical practices that alcohol-associated liver disease is on the rise. It's the current leading cause of hospitalizations among all patients with cirrhosis, and alcohol hepatitis since 2000 has steadily risen, accounts for about 1% of all hospitalizations from data from 2017, a near 28% rise from 2010. And accompanying the hospitalizations, we're seeing a similar trend in mortality. It's continuing to rise since 1999, and specific groups that are at high risk are the young adults and ethnic minorities, which is a change from prior days where alcohol-related liver disease was primarily a disease that affected patients in their 5th and 6th decades. So diving into the history of liver transplantation, going back to the pre-cyclosporin era, looking at the first case series for alcohol-associated liver disease in the transplant, out of the 10 patients that got transplanted, unfortunately only one of them made it past the 4-month mark. And this poor outcome was attributed to extrahepatic manifestations from alcohol. But as immunosuppression improved and the cyclosporin was introduced, 6-month mortalities improved to up to 70%. So this led to the 1983 NIH Consensus Conference, where alcohol-associated liver disease was identified as an acceptable indication for liver transplantation. A small stipulation was put in place that patients should be judged based on who are more likely to remain sober after their liver transplant. Selection should be preferentially given to them. And over the next 8 to 10 years, financial institutions finally agreed and identified alcohol-associated liver disease as an approved indication for liver transplantation, but they added an extra caveat and suggested that a significant period of abstinence before liver transplantation be recommended. They didn't go as far as to define a clear period, but there were some observational studies, again, case series of 11 to 15 patients that suggested maybe a 6-month period of wait time showed better outcomes among liver transplant recipients. And throughout the 1990s, majority of the insurance companies then went ahead and implemented this rule, requiring a near 6 to 12 months of sobriety as a key deciding factor when evaluating patients for liver transplantation, giving veto power over all other factors, no matter how good the patient's psychosocial profile was. This led to the next 2 decades where the 6-month rule was supported despite lack of clear evidence-based medicine behind it, and nearly 85% of US centers adopted this rule, and UNOS in 1997 went as far as suggesting implementing a universal 6-month rule across all centers to sort of have some standardization. And as they discussed this further, the legal team said that this was an indefensible rule, and thankfully didn't put this in place. And despite not putting this in place, majority of the next 15 years or so, majority of US centers continue to implement the 6-month rule, primarily stating that a period of abstinence was a key marker of post-liver transplant sobriety, and then it really helped assess which patients are going to really need transplant versus which patients may spontaneously recover. And we'll look at the more current data to kind of review this in a bit. So how did this change referral practices for majority of our referring doctors, looking at studies from 2007 in the US, greater than 90% of patients with alcohol-related liver disease didn't touch a transplant center during their history of liver disease. Only 4% of patients with alcohol-related liver disease in the US actually got on a transplant list, and only 1.2% of all patients with alcohol-related liver disease in the US got transplanted. So this accounted for approximately 12,000 annual deaths from alcohol-related liver disease in the early 2010s. This is a pre-2010 era. And then in 2011 came the seminal multicenter study from France and Belgium, where they showed a good outcome in early transplantation for severe alcohol-related hepatitis. They were careful about their selection, describing patients who had favorable psychosocial profile, and all patients had to have an initial presentation as an initial decompensation, no prior history of liver disease, who were transplanted with 6 months outcome showing 77% survival. Focusing more on the relapse rate were fairly low at 11%. Patients were most often drinking up 2 years out to the end of the study. Since the 2011 study, multiple other centers have published data. This is looking primarily at the US data up until 2018. We have 4 single center studies and then a large multi-center consortium from Accelerate AH showing excellent data, specifically showing excellent survival in these patients, both at the short term of 6 months and then going further out in the Accelerate study as far as 3 years. 1 year survival was around 90%, and then 3-year survival was 85%, quite similar to other etiologies of liver disease. There's some heterogeneity within the studies on how they reported relapse and then how selection was made, but primarily majority of these patients were patients presenting for initial decompensation of liver disease, as likely alcohol-related hepatitis, with less than 6 months of sobriety. And compiling this data, looking at the UNOS data from 2014 to 2019, there was nearly a 5-fold increase in liver transplantation for alcohol-related hepatitis. And the graph to your right looks at Kaplan-Meier survival curves compared to other etiologies of the liver disease. And alcohol-related hepatitis and alcohol-related liver disease held up quite well compared to the other etiologies, with 1-year survival of up to 91%, and then 5-year survival as high as 81%. So this has really changed the dynamic for alcohol-related liver disease. It's now among the leading etiologies for liver transplantation over the last decade. The graph here shows alcohol-related liver disease in pink, and you've seen significant rise since the 2010s for alcohol-related liver disease. And then came the COVID era, where we've seen a further boom with a more than 100% rise in patients being added to the liver transplants list, and then more than 210% rise in patients being transplanted for alcohol-related hepatitis. So the period of sobriety really is getting shorter and shorter. And looking at centers across different UNOS regions, again from 2014 to 2019, we're seeing more and more centers are willing to accept patients for alcohol-related hepatitis. Have created a protocol for this. And are now transplanting. We've seen nearly a 2-fold increase in the number of centers, going from 14 all the way up to 27. So coming back to the 6-month rule and how does the period of sobriety make a difference? What does the data tell us today? Looking through the studies that I recently mentioned, looking at their relapse rate were quite low or similar to patients who had more than 6 months of sobriety. Again, the way the relapse was defined across these studies was variable. How slips were defined, where patients may go back to drinking but may not have sustained drinking compared to harmful drinking from one study to the next, was variable, but relapse rates were as low as 10% to as high as 28% for any drinking, while harmful drinking was as high as 24% in one of the studies. So looking through these studies, we now understand that a short period of sobriety does carry some higher risks for relapse among patients, but this shouldn't be the only limiting factor when deciding and evaluating our patients, and really need to look at multiple other risk factors for these patients, including what kind of social support do they have, have they had prior history of relapse, and have they failed rehab attempts, what is their insight like, Are they using other substances in addition to alcohol? Have they had prior history of noncompliance with clinical visits? And do they have a family history of alcohol use disorder or any comorbid mental health disorders? There are a few others that I didn't include here, but overall, this probably paints a better picture for the patient than simply looking at their period of sobriety prior to transplantation. So how about waiting 6 months to assess which patients are going to recover versus which patients are not going to recover? This is data from Wisconsin group, a single center retrospective study from the 2012 to 2018 time period, where they reviewed all patients who were evaluated for liver disease with less than 90 days of sobriety. All patients had a ml greater than 25, and among all patients who were evaluated, only 34% of patients underwent liver transplantation. And the graph to the right on the top shows a survival difference between patients who were transplanted versus patients who were not transplanted, clearly showing a clear benefit for liver transplantation. But more importantly, 42% of patients who were denied or did not get a liver transplant did not recover, and only 24% of patients did recover. And when they assessed which factors helped with recovery, patients who were younger were more likely to recover, and patients with a peak MEL score lower than 34 were more likely to recover. In other studies, we know that renal injury plays a key role in recovery. Lack of renal injury is beneficial, and then or preserved renal function is beneficial. History of infections and history of hepatic encephalopathy probably all add to deciding which patients are more likely to recover without needing a transplant versus which patients should probably benefit from proceeding with liver transplantation. Another key finding that I didn't include in here from the study was that most of these patients who were going to recover usually recovered early in their clinical course, usually within 1 to 2 weeks. So if the patients are not doing well over the first couple of weeks, it's probably better that they move forward with the liver transplant evaluation be considered. So we've established that the 6-month rule really doesn't hold a lot of weight, and then the medical community, in particular the transplant community, is recognizing and growingly accepting of a shorter period of sobriety and looking at other factors when evaluating patients. But how about referrals from our referring providers? Looking at a survey of US physicians from 2020, nearly 300 physicians responded to this survey. There's a mixture of medicine, surgery, and other subspecialties. GI was a fairly small group. Family medicine was primarily around 12%. Internal medicine accounted for about 16%. GI subspecialty was around 10%, I believe. And of all the physicians who responded, close to 64% of the physicians had recent transplant training within the last 5 to 10 years. And among the questions asked, when would they consider referring a patient with alcohol-related liver disease, only 31% of patients said that they would refer a patient regardless of their duration of sobriety, which I guess if you're comparing to the 2007 data, to the left where roughly less than 10% of patients were referred to transplant centers, there's been some improvement. But even in the current day and age, more than 68% of providers are hesitant to refer patients, with 26% requiring 1-year period of sobriety and 35% of physicians requiring nearly 6-month period of sobriety. So more work needs to be done on this part to improve the referring practices. So we'll move on to selection criteria, or I guess really a lack of a standardized selection criteria for liver transplantation. In particular, since the focus primarily tends to remain or revolve around minimizing risk of relapse among these patients. The most recent AASLD guidelines suggest echo this thought, where the complexity of alcohol use disorder makes it really difficult to have a single measure that reliably predicts alcohol relapse after liver transplantation. And they went on to suggest having a formal psychological evaluation to separate liver transplant candidates into higher risk versus low risk patients. But really, no real guidance was provided as to how to select these patients, especially when we're picking patients with shorter periods of sobriety. So the Dallas Consensus Criteria offers some guidelines in this area. So this was written primarily to address the growing acceptance of alcohol-related hepatitis and transplantation for it, where patients were selected based on their first presentation for decompensation, as in no prior history of known liver disease and lack of response to medical therapy. And which particular factors to assess for patients with alcohol use disorder was to make sure that the patients underwent a multidisciplinary eval, which is done in most transplant centers. More importantly, assessing these patients when they're coherent. So patients with hepatic encephalopathy, it would make it very difficult to evaluate those patients, making sure that they lacked multiple failed rehab attempts, lack of current substance use, and having a very supportive environment that they can go back to recover after transplantation, with a strong commitment from both the patients and their caregivers to their recovery. Outside of the consensus, there are several other um, scoring systems that are currently in place. CIPAT in particular was initially studied to assess for risk of rejection, compliance, and hospitalization in multi-organ transplantations. Wasn't validated for alcohol relapse, but as in more recent retrospective studies shown to carry some weight. And majority of these other scores provided here have been reviewed either at their single center studies or have some data, small amount of data supporting in other retrospective reviews. SOL score probably requires some highlight here. It's based off the recent Accelerate Consortium, but none of these factors individually are accurate enough to really paint a picture for the patients. So it's important to recognize a patient's alcohol use disorder. This is a busy slide, I'm not meant to read all parts of it, but really to highlight that all our patients with alcohol-related liver disease really carry a secondary diagnosis that requires treatment and early referral. So looking at relapse among patients with alcohol use disorder, it remains the largest area of concern for selection. The real challenge with relapse is we don't have a clear definition. Do we say that patients can't go back to any drinking, or how do we differentiate between occasional relapses where the graft damage may not be present, and how do we truly treat these patients when relapses do occur? More data is needed on trying to assess slips versus harmful drinking. Harmful drinking definitions across different studies are quite variable. Having a unified definition hopefully will provide some more clarity as we move forward. So what are relapse rate like between general populations versus post-transplant liver populations? Untreated patients often will relapse at a rate of around 80+% within the first year, 82% within the 3 years. But if you add some treatment in the form of mutual aid support groups, most of these patients will still go back to drinking in 50 to 60% within the first year. How about if we do more formal forms of treatments like CBT? Depending on the follow-up period, relapse still occurs within these patients. So relapse really is a part of alcohol use disorder. Most of these patients, it's a true journey for them. It takes them a long time to kind of get over or get through their challenges with addiction. The post-transplant data is probably slightly biased to present against the general population, primarily because we are very selective in selecting our patients on picking and choosing those with favorable characteristics to transplant. And despite that, when we compare to the general population, we still see a fair amount of relapse within the patients who were transplanted for cirrhosis with greater than 6 months of sobriety. They carried an annual relapse rate of around 5%, with 3-year relapse rates as high as 50%. Looking at the more recent data for alcohol-related hepatitis, these are patients who were transplanted with less than 6 months of sobriety. They still carried a fair amount of relapse at a range of 20 to 40% over the first 1 to 2 years. So relapse is fairly common and does occur. The important challenge for us is how do we manage it? So let's start comparing relapse to recurrence of other liver diseases which occur after liver transplantation. NAFLD in particular is notorious. These patients often carry some form of addiction to food and probably carry a relapse rate of near 100% at 5 years after liver transplantation. And despite that, they don't carry the same stigma that patients with alcohol-related liver disease do. And then we have our other autoimmune conditions that also occur on a very high basis. The challenge here is that the transplant community, in particular the hepatologists, feel comfortable managing these patients, these disorders. We really lack the training needed to manage alcohol use disorder. And that's, I think, where some of the drawbacks are in supporting these patients after transplantation. The second part probably that's important to highlight is surveillance for these patients. We surveil other etiologies of liver disease fairly frequently with frequent lab tests, frequent imaging tests, probably implementing a similar role for surveillance of recurrence and alcohol use is important. So this is a graph from 2010 looking at single center data from DiMartini, and it highlights that relapse occurs in varying fashions. Some patients may remain sober, throughout the period of the study. Some patients may go back to drinking some nearly 3 to 5 years after transplantation, and then there are others who may go back to light drinking early on, and then some who may go back to drinking within their first year at a heavy level. So continued surveillance for these patients as far out as 10 years is probably beneficial, and then trying to get them enrolled in a multidisciplinary treatment plan for treatment is important. So highlighting again here is behavioral medicine. Implementing them into our post-treatment clinics is probably going to be beneficial, especially because we're seeing a significant rise in alcohol-related liver disease and transplantation for alcohol-related liver disease, and we're really not well equipped to treat these patients based on our current training. Hopefully that'll change down the road. And with that, I'd like to summarize that alcohol use disorder is on the rise, and patients with alcohol-related liver disease really carry two underlying diagnoses, both alcohol use disorder and alcohol-related liver disease. Early screening and interventions are essential for alcohol use disorder, and decision for transplantation is best left to the transplant centers. Growing acceptance for early transplantation for alcohol-associated liver disease is on the rise, and however, there's still a strong need for a standardized criteria across all centers and a post-transplantation management of both alcohol-related liver disease and alcohol use disorder is important in these patients. Okay, questions.